Thank you everyone for coming. This is the September 24th, 2022 version of If You Were My Family Member series. Today, we're going to do something I think is pretty exciting. We're going to focus on stage 4 colon and stage 4 rectal cancer. This is episode 1 of 2. So basically I had to break this up because I was thinking about trying to put everything possible about colon cancer or rectal cancer into 1 hour, and it was essentially impossible. So we're going to have a 2-part series, 1 2-part series for rectal cancer stage 4 and 1 2-part series for stage 4 colon cancer. Now, for each of those tumors, this will serve as the first talk, and then the subsequent talks, part 2 of each series, will be separated out. So audience participation, as always, is encouraged, and I sincerely want you to put whatever questions you have in the chat. That's what we're here for. So when people are diagnosed with cancer, and many people have heard me say this now over the last several weeks talking about other types of tumors, it's completely normal to have stress and panic and phobia and shame and depression. That's a completely normal response to a very abnormal situation, that being having cancer. And what this series is really designed to do is to try and give you a lot of answers to questions that you might currently have that are unanswered, and to really try and help illustrate and illuminate what you're going to basically encounter as you go down your specific path, your specific cancer journey. So hopefully many of these question marks as you're walking down your cancer road will be answered in this talk and then subsequent one. Now, before we even move on, I want people with stage 4 colon cancer, stage 4 rectal cancer, to really appreciate that there's a tremendous amount of hope with this particular cancer. We continue to get better at treating patients with stage 4 colon and rectal cancers, and I think we're going to continue to do so. There's a lot of drugs in clinical trials, many clinical trials ongoing. We're going to talk extensively about that later, probably most likely next week. But just please know you don't have an expiration date. You didn't walk in the room with an expiration label. I would tell that to my patients all the time. And so I want you to very clearly realize that hope springs eternal. It is not unheard of to live a very long time. I have patients who are, 10 years out from their stage 4 colon, stage 4 rectal cancer, and people thought, oh, they would not be around this long, and they're around, and they've got no evidence of disease, and they don't really have a ceiling. I don't have any clear-cut picture as to when something's going to happen. And so I think it's tremendous. Our treatment's very effective in this disease. So what I think is very unique about what we do with this series is, number one, I really try and look at everything from the perspective of a patient as if you were my loved one. If I was in the room with you, knowing what I know as an oncologist, what questions should you ask? What would I want you to know? How would I ensure that you get optimal care when you try and advocate for yourself? And I'm not saying my colleagues are tremendous. They don't need me for this. But the bottom line is, I do think that patients want to advocate for themselves. And I think this is a very good way of trying to do that. Now, what's really unique about this series is I don't just treat stage 4 colon, stage 4 rectal cancer. I treat a lot of it, but I don't just treat that. I treat everything. So I have a very unique way of going from the trees to the forest, to the country, to the continent, to the planet Earth. And that's really what we're going to do here, take you in and out of the forest, the trees, the continent, the planet, and give you a very easily digestible format for basically confronting your cancer and trying to answer those questions that right now are unanswered. So what I want you to do in terms of the sequence of watching these talks, and you don't really have to do this, but this is kind of how it's been built, is I did give a talk called Optimizing Your Ability to Fight Cancer. I think 1,200 people have watched that in the last month or so. That talk is really the foundation upon which all the other talks have been built. So ideally, you would watch this talk at some point. It really just gives you 10 survival tips. It's really kind of an overview sort of talk. It's a little bit softer than some of these other detailed talks, but I think it will help you a lot. This talk here is everything you need to know about stage 4 and stage 4 colon and stage 4 rectal cancer. That's really the overview talk. And then next week, I'm going to talk about treatment for stage 4 colon cancer. And the week after, I'll do stage 4 rectal cancer. So that would be the next talk in your series, just for the colon cancer patients they watch next week, for the rectal cancer patients they watch the week after. There's a subtle difference there. I think it might just be better to separate those out. You can see these talks at revolutioncancer.com. This talk will be made available immediately after this talk on the website. And this talk will also be available on Revolution Cancer channel on youtube.com. So we talk about stage 4 colon / rectal cancer. We really stage these types of cancers, stage 0 through 4. Stage 0, 1, and 2 are restricted to the colon. Stage 3 involves the adjacent lymph nodes. So not just the colon, but the adjacent lymph nodes. And stage 4 is where it has spread beyond the colon and the local lymph nodes. And that's what you're really here to learn about. So when we talk about colon and rectal cancer stage 4, usually it's of an adenocarcinoma histology. Let me explain that. So when you have cancer, we typically look at the cancer cells under the microscope, and we can define what's called their histology, which is really the identity of their microscopic nature. And so most colon and rectal cancers will be of the adenocarcinoma variety. And so if your cancer is not an adenocarcinoma, it's a squamous cell carcinoma, or it's a neuroendocrine cancer or something of that nature, that's different. And you probably need to watch a different talk. And so just make sure your cancer is adenocarcinoma. I'm sure they all are. The squamous cell is subtly different in rectal cancer, but the bottom line is everyone here really has an adenocarcinoma subtype. That's all I want to say on that. The other thing to know is that most stage 4 colon and most stage 4 rectal cancers, when they spread to the liver and lungs. Those are by far the most common sites. It would be very rare for your cancer to go to the brain, although I have seen it. It's very, very infrequent. It would be odd for it to go to the bone. And so really the liver and lungs are the most common locations where these cancers spread. Remember, I said already, there's a ton of hope here and there. You don't have an expiration date. When we talk about stage 4 rectal cancer, stage 4 colon cancer, it's typically diagnosed via a CT scan of the chest, abdomen, pelvis. It's imperative that you get the chest, abdomen, and pelvis, not just the abdomen and pelvis, because remember, this likes to go to the lungs. We do follow a cancer marker in the blood called the carcinoembryonic antigen, the CEA. Some of these stage 4 colon, stage 4 rectal cancers will make this particular protein and secrete it into the blood. So the higher the number, that tends to correlate with the higher amount of disease, higher amount of cancer burden. And so we follow that marker because we want to see it go down, because of course, if we're killing cancer cells, they can't make the protein, so the protein should go down. So it's a nice way of following your disease. I always tell people the scans matter far more than the CEA. The cancer marker is just a number. I really care predominantly about the scans. But when you're doing these CT scans every 2 to 3 months, it's nice to follow the cancer marker in between. Of course, we always do a biopsy to prove that you have stage 4 colon, stage 4 rectal cancer. So I really never make assumptions. So the idea would be, okay, we see a spot in the liver we think is coming from the colon. We need to biopsy that spot to ensure that it quacks like a duck, looks like a duck, but it actually is a duck. Now, people always ask me about PET CTs. I think PET CTs can be useful in this disease. Some colon and rectal cancers take up the glucose tracer that we give in a PET CT, so you can sometimes follow them very nicely. But the overall consensus among experts in the field is that PET CTs are not useful because a lot of these cancers don't take up the tracer. I agree with that. So more often than not, you're just going to be followed with a CT scan of the chest, abdomen, pelvis, and the CEA. So here we can see stage 4 colon patient. On the left, they have disease in the liver. There's multiple spots here in the liver, okay? And here's a patient with disease in the lungs. There's a spot here in the right lung, spot here in the left lung. It's reversed. But that's just to kind of make you aware that we do these CT scans, obviously CT of the chest, CT of the abdomen. We look for these spots that we think are coming from the colon cancer, and then we typically will biopsy one of them to prove that it is stage 4 colon cancer, stage 4 rectal cancer, that it quacks like a duck, looks like a duck, but it is a duck. I don't really make assumptions. It's not my style. So, in general, there's always exceptions, but for the most part, I always get a biopsy. So you would just here in this case, just take a needle, go through the skin, go into the liver spot, take a small piece, and then test it. Here you could go through the skin and biopsy the lung spot. So one thing I need to make explicitly clear, and I've said this before, it's on the first talk I gave, it's in every single talk I pretty much give, no two stage 4 colon or stage 4 rectal cancer patients are the same. It is imperative that you realize that and remember it, because you're going to read all sorts of studies and you're going to encounter all sorts of data. You're going to say, okay, is this me? Well, the bottom line is that data corresponds to a lot of different people, none of which have exactly what you have. I guarantee you, none of them are exactly like you. They don't have the same medical history. They don't have the same location of the cancer, the same amount of the cancer, same molecular profile. They're just not the same. So please take that with a grain, take those studies with a grain of salt. Yes, they're nice when you look at population means and you look at sorts of like averages, but the bottom line is that's not you, okay? So the way I think about stage 4 colon or stage 4 rectal cancer is I kind of think of it on a continuum, right? So there are some stage 4 colon cancers or rectal cancers that are incredibly aggressive. They would be over here on this aggressiveness continuum. And there are some that are slow growing. There are some that you present with just one spot in the liver and it's very slow growing. And so I'm always trying to figure out where my patients are on this continuum. It's really important. It helps me kind of figure out how I want to treat them, where we're going, things of that nature. We're going to talk extensively about that today, okay? So your stage 4 colon or rectal cancer is exactly that. It's your colon or rectal cancer. okay? It can have a different molecular profile than someone else's, a different growth rate, different amount of cancer, different locations of the cancer. This is very important in stage 4 colon rectal cancer. We'll talk about that in a moment. And I want you to try and understand your specific cancer. I want you to think about, okay, how's it been responding? How aggressive is this? Where is it located? How much cancer is there? And I want you to really focus on your molecular profile. Things of that nature we'll go through extensively today, in a way I don't think you're getting from anyone else. I would be shocked to be getting this anywhere else. So we want to think trends, not snapshots. That's imperative. So yes, you walk in today with a scan that looks like A, okay? But I'm really interested in what the scan looks like 3 months later or 2 months later, right? And so I don't really focus on the snapshot. Yes, it helps me try and figure out what I want to do, but I'm thinking more along the lines of trends. How are you responding to treatment? What's the CA doing? Where are we with the next scan? That sort of thing. And I want you to ask to see your scans. Now, this is imperative because everyone's cancer is different. And because the amount of cancer and where it's located has a profound impact on how you will do and how you will be treated, I want you to pin your cancer doctor down and to say, okay, show me my scans. I want to look at them. I want to look at them before and after treatment. I want to look at them every time I have a scan. I want you to do that. I show my patient scans all the time. You know, I was talking to someone online, a patient, and they said, you know, it's not fair for me to ask my physician to see my scans because they're on time. Well, that's garbage. I see patients just as many as they do. I, sometimes see 30 patients a day, sometimes responsible for 70 in a day, 30 in clinic and 40 in the hospital I've been responsible for, which is crazy. But the bottom line is I show my patients their scans. It's my obligation as a physician. They need to know how the disease is doing. They need to understand their symptoms based on where the tumor is located. They need to get the feeling of positivity when we do well. It's nice to see that. And so I think it's really important. Now, when I talk about cancer, I wrote this article called Quarterbacking a Patient's Cancer Care. And I think it's a really nice article that really shows what the oncologist is thinking about when we confront your cancer. I wrote this article where you can see on biopharmatrend.com. It's actually here. Just put my name in, put in biopharmatrend.com and you can see it. But the bottom line is I want you to know your opponent. You know, when I line up at the line of scrimmage and I'm facing your cancer as basically you're the coach and I'm on your team, I'm trying to understand what that opponent really looks like. So when we talk about understanding your cancer, understanding the opponent, the very first thing I want to talk about is the molecular profile. Now, a lot of people don't go through this because they think it's too complicated for patients. I think that is garbage. What I have discovered really talking to patients and understanding what's going on in their support groups and the like is that they know a lot. Like you guys are incredible at what you know. Like you're up to date on clinical trials, you're up to date on molecular sequencing, you're really up to date. So in this particular series, I'm really taking it up a notch. I'm like, basically teaching you as though you were an oncologist, like, the brand new stuff. Well, next week, we're going to talk about all the new clinical trials, talk about all the new data. Like I'm going to really give you a full review because I've really realized of late that you guys know a ton of stuff. And to provide you value, I can't just talk about the stuff that's pretty simplistic and that you probably already know. I have to kind of go to the next step. And so I'm really going to talk about molecular profiling here in a way I think is easily digestible, but in a way you have to know. And you might already, but the bottom line is I need to go through this. So molecular profiling is a way of understanding the genetic and protein composition of your cancer, okay? It's basically, for me, a reflex for theoretically incurable cancers or even stage 4 cancer. So you walk in with stage 4 colon cancer, stage 4 rectal cancer, you've got to immediately have molecular profiling. It's imperative. I mean, essentially every doctor does this, but you want to see it, you want to know what's happening, okay? Now, when I say molecular profiling, I'm really talking about these things in green. And don't make it too complicated. All you literally have to do is write down what's in green. You can even write down the acronyms, take it to your doctor, they'll know, and just say, hey, can I see the results of this? I'm sure you sent it. Can I see the results of this? You don't have to know anything else I'm about to show you. As long as you know that, I'll walk you through the rest later, but I'm going to go over this in detail so you kind of have some good feeling for this though. So first and foremost, we do something called next generation sequencing. It's a way of looking at the mutations in your cancer cell. So what happens is we basically will test your cancer for various mutations in the DNA. And the idea is if you have a mutation, say in a purple gene, we might be able to use a drug, a purple drug that targets that purple gene. Similarly, if you have a mutation in a green gene, we might be able to target the mutation with a green drug, orange gene or orange mutation, orange drug. And that's really important. We have various drugs we use or don't use based on the mutations in the cancer. We're going to talk about that extensively. In addition, we sometimes we want to know, always want to know, if you're a candidate for immune therapy. So immune therapy is treatment that's designed to recruit your immune system, to rev it up and have it attack your cancer. That's the idea behind immune therapy. It's designed to stimulate your immune system to essentially kill your cancer cells. And the way we find out in stage 4 colon and stage 4 rectal cancer, if you're a candidate for immune therapy or a good candidate for immune therapy, is we do these tests called PD-L1, tumor mutation burden, and microsatellite instability. Now, microsatellite instability is by far the most important. We're going to talk about that later, but it's abbreviated MSI. This is critically important in stage 4 colon and stage 4 rectal cancer. If your cancer has a high amount of microsatellite instability, we say MSI high, your cancer can have a profound response to immune therapy. I have patients on immune therapy who are MSI high 5 years later with no evidence of disease, no cancer out there. It's incredible what immune therapy can do for patients who have high microsatellite instability that are stage 4 colon or stage 4 rectal cancer patients. So you have to know what that looks like. There is something called homologous recombination deficiency, HRD. That basically, if positive, suggests that you might respond to a drug called a PARP inhibitor, poly-ADP ribose polymerase. That's not as important in stage 4 colon and rectal cancer, but it is still nice to know. So I want you to write down NGS, TMB, PD-L1, MSI, and HRD. Take that to your doctor and ask if it was done and look at the results. So when we talk about molecular profiling, and now we're talking about the NGS part, the mutation screening part, there is a very important set of genes that we are interested in. We're interested in a gene called HRAS, H-R-A-S, gene called NRAS, so N-R-A-S, and a gene called KRAS, K-R-A-S. These genes make proteins that basically correspond to the gene. So HRAS gene makes the HRAS protein, NRAS gene makes the NRAS protein, KRAS gene makes the KRAS protein. RAS is in this pathway of proteins in our cells, okay? So there's this pathway that starts with this protein called EGFR that recruits this other protein that essentially activates the RAS protein, eventually leading to proliferation of the cell. So let's back up for a minute. So cancer is just a cell that grows in an uncontrolled way. That's it. Breast cancer, breast cell, lung cell, colon cancer, colon cell. Now, we have various pathways in the cancer cell that can trigger that cell to divide, okay? And one sort of mutation the cancer cell can have is a mutation in this RAS protein, where it basically leads to that protein being on all the time. So when this protein's on all the time, it's basically telling this particular cell, the cancer cell, to divide all the time. And that's what cancer is, right? So it's very important for us to know if your cancer, your colon cancer, has a mutation in HRAS, NRAS, or KRAS. Now, part of the reason for that is because we want to know if we can use a drug that targets a protein called EGFR. And there's two drugs that do that, a drug called cetuximab and a drug called panitumumab. So let's back up for a minute. This is a lot easier than it sounds. On the surface of the cancer cell, there's a protein called EGFR right here. Okay, that's right here, this blue protein. Now we have drugs that can basically block this protein. So we have a drug called panitumumab, another drug called cetuximab, and they work by blocking this protein, okay? They will not be helpful in your case if you have a mutation in a protein that's downstream of it, so downstream of the EGFR, because this protein will already be active and already tell the cell to divide, and it doesn't care what's happening upstream of it. So even if you block this protein, it doesn't matter because this protein is already turned on and it turns everything else on. So we want to know if you have a mutation in this protein, so either HRAS, NRAS, or KRAS, because if you do, then the drug that targets this protein, either panitumumab or cetuximab, will not work. And that's really important. So one big question in your disease is, do you have a mutation in one of these genes? Because if you do, you cannot really get these two drugs. And that's really important. We'll talk about that later, but that's all I want you to see, okay? Now, another thing that's important to know is that there are now a lot of clinical trials looking at patients who have specific mutations in one of these genes. So if you have a mutation that we call G12C, which essentially means that the glycine at position 12 of the protein has converted to cysteine. If you have this mutation, don't worry about that. Just if you have this mutation in the KRAS gene, there are clinical trials ongoing looking at drugs, like a drug like sotorasib, that targets this specific mutated protein to try and defeat your cancer. So you would want to look for something like that. You say, okay, I have a KRAS G12C mutation. Let me see if there's a sotorasib, another drug called adagrasib trial that I can maybe be on, right? And so that's really important. In addition, sometimes there's a mutation in KRAS called G12D, not C, D, where they have other drugs that target that specific variant that might be useful for you. So that would be a good, nice clinical trial for you to be on too. So don't make it too complicated. Bottom line is, you want to know, is there a mutation in HRAS, NRAS, or KRAS? Okay. And if there is, you know that you can't really get these two drugs, these EGFR inhibitors, but you also know if it's this type of mutation or this type of mutation, maybe there's a clinical trial that would be useful for you. Now, this might get a little confusing. We do use one of these drugs with this other drug on that trial. But the bottom line is, you want to know if there's a mutation in one of these genes, because you can't get these drugs if there is, unless there's a clinical trial that uses them. Okay, good. So that's KRAS, NRAS, and HRAS. Let's move on to a different gene that's also very important in stage 4 colon, stage 4 rectal cancer. This gene is called BRAF, B-R-A-F, okay? And there's a specific mutation in this gene called V600E, okay? So again, it's valine converted to something called glutamic acid at position 600, does not matter, okay? What happens if you have this particular mutation is you are a candidate for a regimen that we call encorafenib plus cetuximab. Encorafenib is a drug that targets that mutant protein. So essentially what happens when you have this mutation is that this protein here, when it's mutated, okay, is active in a way it should not be. So it's triggering the cell to divide, okay? So what they do is they say, okay, let's block this protein with this drug when it's mutated, and we'll also try and block this protein upstream of it to see if it helps, and it certainly does. In this case, we know that. So if you have this mutation, then you will almost undoubtedly at some point in your life get this treatment that's encorafenib plus cetuximab. So that's really important to know. So really all you have to know here is, do I have this mutation? If I do, at some point I'm likely to get these two drugs in combination. That's it. So here you can see a patient who had a pretty big spot in the liver, okay? You can see the spot here, and then they got the treatment. They had a mutation in this gene. They had the V600E mutation. They got the drugs, the encorafenib plus cetuximab. You can see the spot is gone, right? So it worked very nicely because they had this mutation. So you want to know, just by your molecular profile, just get it from your doctor, do you have this specific mutation? And if you do, you would be a candidate for this treatment. Another gene that's very important to know if you have a mutation in is something called HER2. So HER2 is a protein. It sits on the cell surface, on the cancer cell surface. It's on all of our cells, but on the cancer cell surface. And when it's mutated, it basically triggers the cell to divide. I'm not going to go through all of this. The bottom line is it sits on the cell surface. Okay. So if you have a mutation in this HER2 gene, then you're a very good candidate for drugs that we use to target that mutation. So we have a drug called lapatinib with a drug called Herceptin. And there's also now a drug called tucatinib, which had very nice data recently. I think it will be approved with Herceptin that can also work. So you want to know, do you have a mutation in HER2? Because if you do, you will be do you overexpress HER2? Sorry, do you make too much of it? Or do you have a mutation in it? But really, do you make too much of it? Okay. If you make too much of it, you would be a very good candidate for lapatinib plus Herceptin or tucatinib plus Herceptin. So you just want to ask your doctor, do I make too much HER2? Does my cancer cell make too much of it? Or is there a mutation in the protein? And then you might be candidates for these drugs. They would be very useful for you. So you want to know your molecular profile. Here's a patient, right? Had this liver spot in their colon, and they basically had a HER2 amplified, so too much of the HER2 protein, right? That led to activation of the cell and caused it to divide. They were basically put on lapatinib and trastuzumab, both drugs targeting this HER2 protein. And you can see that this spot was gone, and their cancer marker, their CEA, which is like 1100, went all the way almost to 0. And you can see here, actually, it's very nice. This is almost a year later, and things look very, very good. So this is really important, right? I'm only showing you this stuff because I want you to know it. You don't have to know the details, but you have to say, okay, let me go ask my doctor about RAS. Let me go ask my doctor about BRAF. Let me go ask my doctor about HER2. That's it. Just write this stuff down. Just say, hey, do I have these mutations? And then know that there are drugs that we use to target. So here you can see there's a lot of nice drugs in clinical trial in colorectal cancer, so colon and rectal cancer, that are being tested. So if you have abnormal levels of HER2, like you overexpress this, there are a ton of drugs being tested, and just make sure you ask your doctor about it. That's all I want to show you here. Now, there's something called an NTRK fusion that we look for. This is really rare, like really rare in colon cancer. But if there's a fusion on the molecular profiling in a protein called NTRK, you would be eligible for a drug called larotrectinib or entrectinib that can help basically combat your cancer with that fusion. And here you see a very nice example of a patient with this very big mass who had an NTRK fusion. And when they were put on larotrectinib, you can see that in 5 weeks, the mass has shrunk significantly. Very nice shrinkage of this mass. It's now a third of what it was because they had this fusion, because they were put on a drug that targeted that fusion. So I want you to ask your doctor about the molecular profiling. That's it. Just say, hey, am I a candidate for a drug based on the mutations in the colon cancer or rectal cancer cell? So here I kind of listed them for you. You can write them down. These are the big ones, but really there's some other mutations we look for. It's much more subtle. I don't want to go through that, but just write this stuff down and say, hey, did I have any of these abnormalities in my colon cancer cell? And really NTRK is kind of a more rare one, but just ask your doctor about these particular abnormalities. That's it. That's all I need you to know, okay? So let's talk about immune therapy. So immune therapy stimulates your immune system cell to eradicate your cancer cell, okay? And so we want to know if you have different facets of your cancer cell that suggest it will highly respond to immune therapy. So it is good. It's like the go-to treatment for patients that are MSI high or mismatch repair deficiency. Let me explain that. So we generally will start with immune therapy as opposed to chemotherapy for patients who have a high level of microsatellite instability or a mismatch repair deficiency in their cancer. I'm going to explain that in a moment, but these are two things we look for. And if you have them, the first treatment you're going to get is probably going to be immune therapy, not chemotherapy like other patients who do not have this abnormality. So let's talk about that a little bit more. I'm going to talk about that here. So MSI stands for microsatellite instability, okay? And so what happens is you basically have unstable DNA. I don't want to go through all of this right now, but the bottom line is your DNA is unstable. And when the DNA is unstable, it makes a lot of weird proteins, okay? The cancer cell does. So when the cancer cell has a lot of DNA instability, otherwise kind of suggested by this microsatellite instability being high, when there's a lot of high DNA instability, high microsatellite instability, you get a lot of weird proteins that the cancer cell makes. And that basically triggers the immune system cell to come and attack it and kill it. So when we give immune therapy to really rev up the immune system cell, that's very helpful in patients who have a high level of MSI. Okay, so if your cancer is MSI high, there's a lot of this DNA instability that is suggested by this microsatellite instability test, then it really suggests you're going to be a great candidate for immune therapy, and that'll be the first treatment you would get. Another kind of thing to think about is if your cancer has what's called mismatch repair deficiency. So in our body, we have proteins that help repair DNA when there's different mutations that are incurred, okay? If there are deficiencies in a set of proteins that are involved in mismatch repair, then it's very likely your cancer will respond to immune therapy. So you're just gonna go to your doctor, okay, make this really simple. You're gonna say, hey, was my cancer MSI high? Was there a high level of microsatellite instability? Or did my cancer have a deficiency in mismatch repair proteins? If either one of those is true, then you are a very good candidate for immune therapy. And the nice thing about immune therapy is it tends to be very safe and it's incredibly effective in patients who have a high level of microsatellite instability or a high level of mismatch repair. So you can see here, this is a very nice example of a patient who had high microsatellite instability, so MSI high. Okay, they were treated with immune therapy. This is immune therapy here, 2 different drugs. And you can see that this very big mass essentially went away when they were treated with immune therapy. So that's really wonderful, okay? So there are different immune therapies you can get. You can get a drug called Opdivo, you can get a drug called Keytruda, a drug called dostarlimab, also known as Jemperli, or a drug called ipilimumab with Opdivo. So these are the kind of 4 different combinations we use. But the bottom line is if you're MSI high or you're deficient in mismatch repair, so deficiency in mismatch repair, you're a very, very good candidate for immune therapy. And I love immune therapy in patients like this. I've at least had roughly 5 to 10 who I've treated like this, and they've done, all of them have done unbelievably well. Like I love it when I see it because it provides a ton of hope. So make sure that you ask your doctor about it. Now, I do want to be clear about something. Only about 3 to 5% of patients with stage 4 rectal cancer or stage 4 colon cancer will be MSI high and or deficient in mismatch repair proteins. So not a whole lot of people will be candidates for this, but when you are, if you're one of those 3 to 5%, it's revolutionary. Like It's amazing. In fact, some of these people we think might be cured with immune therapy. We don't know yet, but it's pretty amazing what we see in terms of responses with immune therapy. So you can see here that actually won't go through that, but the bottom line is immune therapy works very well for people who are MSI high and have colon cancer. This was a trial they did in rectal cancer that was published in the New York Times, showing that patients with deficient mismatch repair enzymes, so that were mismatch repair deficient, responded very nicely to immune therapy. That was actually in stage 2, 3 in colon cancer, stage 2, 3 rectal cancer patients, not stage 4. But this was also a nice trial just showing that if you're deficient in mismatch repair or you're MSI high, you can respond very nicely to immune therapy. So here's a kind of an example of that. So here's a patient with rectal cancer. Okay, so this is the rectal cancer here, right? You can see the rectal cancer. And they had a deficiency in mismatch repair proteins. You can see 3 months after getting immune therapy, that cancer is gone, like entirely gone. And so that's pretty awesome, right? Here's another patient, okay, 3 months later, you can see, and then 6 months later, cancer looks like it's really gone. So this is wonderful to see, well, much smaller. So wonderful to see, and I think that it's very important for you to ask your physician if your cancer is mismatch repair deficient and or MSI high. So another thing to ask about is something called tumor mutation burden. So tumor mutation burden is exactly what it sounds like. How many mutations are there in the cancer cell DNA? And what we know is the higher number of mutations, the more likely you are to respond to immune therapy, okay? Take that with a little bit of a grain of salt, but the idea is pretty simple. When there's a lot of mutations in the cancer cell DNA, they make a lot of weird proteins. Your immune system cell recognizes those weird proteins and says, okay, I got to take care of this cell, I got to kill it. So when we give your immune system immune therapy, right? We rev up your immune system to try and target such cells, they work amazingly. So we know that the higher the level of mutations, right? That's shown here, the higher level of mutations, the more likely you are to respond to immune therapy. So I want you to ask your doctor if your cancer has a high level of tumor mutation burden, so TMB high. Now, one thing I didn't talk a lot about is something called PD-L1. So I can go back to that actually, let's do that for a moment. So there is something called PD-L1. So that stands for programmed death ligand 1, okay? So PD-L1 is a protein that some cancer cells will make, that's shown here, and they'll insert it on the surface of the cell. And what that does is it will bind to a protein called PD-1 on the immune system cell and turn it off. So this is a cancer cell's way of avoiding your immune system. It basically puts this protein on its surface. That protein binds to a surface on the immune system cell and turns it off. So what we can do is if your cancer cells make a high level of this protein, like if a huge number of them make it, we can basically say, okay, let's try a immune therapy that blocks this PD-L1 on the immune system cell from interacting with the PD-1, the PD-L1 on the cancer cell interacting with the PD-1 on the immune system cell. And when they would do that, if we block that interaction, so that's blocked here, right? Basically what happens is the cancer cell now can go and attack the immune system cell. So we block this interaction with this immune therapy, and now the immune system cell wakes up and kills the cancer cell. So if your cancer makes a high level of PD-L1, we will oftentimes use immune therapy. This is actually wrong. It's PD-L1 10% is wrong. Sorry, this is a different slide. Bottom line is, if your cancer cells make a lot of PD-L1, I want you to ask your doctor if you're a candidate for immune therapy. So collectively, when we talk about kind of everything, I want you to ask your doctor if your cancer makes a lot of PD-L1, forget this 10%, 1% or more is actually considered positive. But if it makes a lot of PD-L1, if it's MSI high, if it's deficient in mismatch repair proteins, or if it's TMB high, if it has any of these characteristics, you might be a very good candidate for immune therapy. So all you really need to do is say, hey, is my cancer MSI high? Is my cancer deficient in mismatch repair proteins? Is it TMB high, and does it make a lot of PD-L1? If any of those answers are yes, I want you to ask your physician, am I going to get immune therapy? Okay, that's really important. The last thing to talk about is something called HRD. I'm actually going to blow through this, but you can just ask your physician if you have HRD, because you might be a candidate for something called a PARP inhibitor, poly-ADP ribose polymerase inhibitor. One of them is called olaparib. So just say, okay, do I have homologous recombination deficiency? So ultimately, when we talk about molecular profiling, right? So I remember, when we talk about stage 4 colon, stage 4 rectal cancer, we need to understand the genetic and protein composition of your cancer, because it impacts your treatment, it impacts your outcomes. I don't want you to worry too much about the details, but I want you to ask about molecular profiling. I want you to specifically ask about next generation sequencing. I want you to say, hey, what about PD-L1, TMB, and MSI? Okay, and I want you to say, what about HRD? Just take these to your physician, also MMR, but just go to your physician and say, hey, what did these results show? And what does it mean? Okay, and so these are kind of the things we're looking for. We're looking for PD-L1, MSI, and TMB. These kind of help us judge if you're a good candidate for immune therapy. I should put MMR here too. We're looking for these mutations that we talked about earlier, and we're looking for these mutations as well. That's kind of the moles recombination efficiency part. Bottom line is just write these down, literally just write them down and just say, hey, what did these show? And I'm going to talk about this more in detail in a little bit later in this talk. So this is a patient of mine, okay, stage 4 colon cancer, had all these different mutations, right? Was MSI high. So you can see this in the report. You can just grab your report and you can see it yourself. They had a high amount of tumor mutation burden, so it should be 10 or less. So it's 55. And because of this, we started her on immune therapy, okay? 4 years later, after starting this immune therapy, because she was MSI high, she has no cancer. Like, she's doing amazing. She might actually be cured from immune therapy. It's amazing, right? But not only that, but she also had a fusion in this protein called NTRK. So we could even use a drug that targets that. And that also can be quite helpful in colon cancer, has a relatively reasonable response rate, roughly 25%, which is not terrible. But the bottom line is we have a very good treatment for patients who are MSI high. So I need you to ask about that. And I'll come back to that later. So when we talk about stage 4 colon cancer, stage 4 rectal cancer, I wrote this article on bioinformatory.com. You can see that here, called Playing Chess Against Cancer. I want you playing chess, not checkers against cancer. What does that mean? Well, I want you to say, okay, when I have my cancer, how am I going to attack this? What am I going to use first? What am I going to use second? What am I going to use third? What am I going to use fourth? And the way to do that is to say, okay, what are the conventional options available to me? What are the chemos that are already approved? The immune therapies that are already approved if my cancer is MSI high or something like that? What are the operational options? Does surgery have a role here? I'm going to go through this in detail a little bit later, but you can see, does surgery have a role here? Are there molecular-based options? So we just went through all that profiling, right? Something in that profiling, in the genetic composition of your cancer, might say, hey, you could use this drug or this drug. And so the patient I just showed you had all these different options because of the mutations in her cancer cell. Local regional options like Y90 radioembolization, I'm going to talk about in a moment, but that'd be another option. And then Charles, forget the hospice thing. That's kind of something I was showing in this other article. So we talked about molecular profiling. We started by saying, okay, no two cancers are the same. And then we said, okay, let's look at the molecular profile. Now we're going to look at some other things. So some other very important things to know about your stage 4 colon or stage 4 rectal cancer is the location of the disease. Now, what do I mean by that? We already talked about how the two most common sites of cancer spread are the liver, as shown here, okay, or the lungs, which I showed you earlier. Now, what's very important to know is that with stage 4 colon cancer, stage 4 rectal cancer, unlike a lot of other cancers that are stage 4, we can actually cure a significant number of these. And we cure them largely by doing a multi-modality approach. We'll use surgery and chemo and sometimes radiation. And so it's very important to understand that if you have a certain constellation of cancer with your stage 4 colon or stage 4 rectal cancer, we can potentially cure that. So it's incredibly important to know where your cancer is. So look at this, for example. Here we have 2 stage 4 colon cancer patients, okay? One has a lot of cancer in the liver. This is not something we would be able to cut out. That's too many spots. We wouldn't be able to cure this patient, but we can certainly do a lot here. Don't get me wrong. There's a lot we could do to help this patient, but we can't cure them with surgery. However, this patient just has this one spot here in the liver. This patient's highly curable with surgery. So we take this spot out, we give them chemotherapy, we take out the spot in the colon, and this patient could very well be cured. So it's very important to realize that these 2 patients are not created equal. We take very different approaches with these patients. And this patient here with the solitary spot in the liver has a relatively high chance of cure, all things considered. So knowing the location of these and the amount of cancer is so incredibly important. So you have to ask your physician to see your scans. Absolutely. Stage 4 colon, stage 4 rectal cancer, you've got to see your scans. You've got to ask them, is there a curative approach here? And I'm going to give you a very stepwise manner to ask these questions. I promise you. Okay. Now, the other thing to think about is that stage 4 colon cancer, stage 4 rectal cancers can have different patterns of growth and different response. I call that the cancer biology. So I'm always trying to get a feel for my particular patient stage 4 colon or rectal cancer, right? There are no 2 cancers the same. So when I'm seeing my patient, I'm not thinking about any other patients. I'm not thinking about, oh, this patient should do this because all these other patients did this. That's not really how I'm thinking. I'm thinking, okay, how do I determine what this patient's stage 4 colon cancer is going to do, right? When I give this treatment, when I look at the next scan, how they respond, because that gives me a feel for their specific tumor biology. So I want you thinking about your specific cancer, trying to get a feel for your cancer. Also, as we talked about, the amount matters. And it matters a lot because if there's a small amount of cancer in the liver, that's potentially curable. So it really defines, can we cure this or not? And cure is very different than palliation. Palliation means we're giving you treatment forever to keep your disease at bay or whatever. That's very different than being cured and never having to come back in my clinic or coming once a year or whatever, right? So the bottom line is you want to chase cure when it comes to stage 4 colon and rectal cancer. And to do that, you need to understand where the disease is. I'm going to talk about that in a moment. In addition to just trying to chase cure, knowing the amount of cancer helps know if you have room for error, right? If you've got a lot of cancer, like in this patient in the liver, there's not a lot of room for error. If you get the first treatment wrong, that's going to be a problem. There's already a lot of disease here. However, with this patient, you get the first treatment wrong, you've got a lot of room for error. It affects the attack options, so it can help you decide, can you use something called radioembolization or not? So for example, this patient, if their disease was just restricted to the liver and there's nothing else in the lungs of that nature, and you can see actually some fluid here, but let's say the disease was restricted to the liver, you could potentially do something called radioembolization, where you inject these radio-labeled beads, so these beads coated with radiation, into the liver to try and kill the cancer, something called radioembolization. I'm going to talk about that in a moment. Location matters. Liver and lung, typical sites of disease where the cancer goes, but that matters. It helps us understand how to treat you and understand your symptoms. So if you come to me and you say, I'm having shortness of breath and there's a lot of disease in the lungs, that helps me understand why. That would be relatively rare, by the way. But the bottom line is I need you to see your scans. That's really, really important. You have to ask to see your scans. So please know that when we see patients with stage 4 colon or stage 4 rectal cancer, we are trying to figure out where they are on this continuum, right? So we talked about how no two patients are the same. They're just not, right? Some have stage 4 colon cancer or rectal cancer that grows very fast. Some have a disease that grows real slow. And I'm trying to figure out where you are. And remember, what happens is always more important than what you think should happen. Cancer does not read textbooks. It doesn't care about averages. It doesn't care about what I think should happen, right? So just think about you. Don't worry about all these different statistics you're hearing. That's not that important, to be honest. You want to focus on you and just understand that, yes, it helps determine what the right treatment should be. But beyond that, it doesn't matter, right? Because I'm only focused on you. It doesn't matter what happens to patient A or patient B or patient C. All that matters is how you're going to respond to treatment. So just remember that, okay? Yes, we use these studies to help us determine how to treat you, but after that, it doesn't matter because all that matters is what happens. Everything depends on this, as you know. We're thinking trends, not snapshots. I'll come back to that. And then we're thinking about treatment breaks and maintenance regimens. So the way we typically address stage 4 colon cancer or stage 4 rectal cancer, that's not necessarily curable, is we typically hit it pretty hard initially, right? We'll hit it really hard initially. And we'll say, okay, we beat this down pretty badly, but we can't keep beating you up with the treatment we're using. So then we'll say, okay, we're going to try and go to a maintenance treatment to keep this at bay. Or sometimes we might even give you a break, right? A treatment break. And the only way to really know if we can use maintenance therapy or a treatment break is by seeing what's happening to the cancer. If your cancer's growing rapidly, I'm not going to say, okay, let's go to maintenance treatment. It doesn't make any sense, right? I'm not going to say, okay, let's give you a treatment break, not if it's growing really rapidly. So understanding what's happening to your cancer at all times is really important, because when we think about trying to take our foot off the gas, right, try and give you a little bit of a break, we need to know what's happening to your cancer. So again, I need you to see your scans. I don't care if the doctor's too busy. I really don't. You're paying a lot of money to see us. You pay a lot of money for the scans. Make sure you see them. Again, we come back to playing chess against cancer. So here's how it works. So I made this article. I kind of built this algorithm for patients, really easy to understand. Think about this acronym. We call it the COMET acronym. So every time you see your physician, you're going to ask about these options. You're going to say, okay, I'm going to run through this COMET acronym. I'm going to take them one at a time and say, okay, what is my conventional option? What's my operational option? What's my molecular-based option? My everything else in trials. I'll come to that in a minute. But you'll start by saying, okay, what are the conventional options? So this is really the FDA-approved treatments, the chemotherapies, the immune therapies, and all of that. You'll say, what's my surgical option? Is there a role for surgery here? Can we go and cut out the spot in the liver? Can we cure this, right? That's what you're going to want to know. So you'll say, okay, what are my operational options? The M stands for molecular-based options. So you'll say to your physician, you'll say, hey, was I MSI high? Was I TMB high? Was I PDL1 high? Did I have, a BRAF V600E mutation? And really you're asking them because you want to know if you can use drugs that target those abnormalities. So you can just literally say to them, hey, what were my molecular-based options? You don't have to worry about any of this, right? I'm taking you to the trees and the forest and the country. But the bottom line is you say, hey, what were my molecular-based options? Okay. Then you say, what were my clinical trial options? Okay. What are the clinical trials you have? Is there a way to do better here? Are there experimental drugs that look really good or have tremendous potential? Can I be on those? And then everything else really stands for local regional therapy. So what do I mean by that? Local regional therapies are treatments we use to attack a specific facet of your cancer, one location, like radiating one spot in the lung, or doing radioembolization, where we basically use the radiation-encoded beads like I talked about and insert them into your liver, in the arteries of your liver. So that we'll be attacking just the disease in the liver. Those are local regional approaches. So you're going to ask your physician, what are my conventional options? What are my operational options, my molecular-based options, my everything else in my trials, okay, my local regional options. And so that's really important. So the way it works, right, with all of this information in hand, is we basically say, okay, we have a stage 4 colon cancer, stage 4 rectal cancer patient. We basically say, okay, we're going to treat them in the first line. We're going to give them our first therapy. We call it first line therapy. And we're going to use it until either it stops working, or they can't handle it, or they're cured. And I should have put cure here because that's actually unique to stage 4 colon and rectal cancer patients. But you might be cured, right? You may not need any more treatment after that. But the bottom line is, let's say you're not cured. If you're not cured, then we use a treatment until it stops working, or you can't handle it. Then we go to our second treatment called second line treatment. We use that until it stops working, or you can't handle it, and then so on and so forth. And so what you're doing as a patient, and what you want to know is, you want to know what your treatment map's going to look like. Okay. What I mean by that is to say, okay, we take all of our options. We take our conventional options. Let's say there are 5 of them. We take our molecular-based options. Let's say you have mutations in these different genes that allow us to use these options. Let's say these are the clinical trial options. Let's say you have a surgery option, radiation option, et cetera. And then you say, okay, how do I sequence them in the best manner to prolong my life and make it of good quality, right? Now, this is a little complicated. Don't worry about that. I'm going to kind of go through it in more detail. I'm going to make it very simple. Like, I'm going to walk you through your treatment map in a way that I don't think anyone really is, okay? But this is the big picture. And I only want you getting the big picture. The big picture is, we have kind of these 5 different modalities of treating you, 5 different kind of thought processes. And we say, okay, how do we combine them to optimize your chance at living a very long time with a good quality of life, okay? But please understand, first and foremost, that we are aggressively going to chase cure. Remember, I already said, stage 4 colon cancer, stage 4 rectal cancer, as opposed to stage 4 breast and a lot of stage 4 lung, is actually curable in a lot of situations. And determining if a patient's curable oftentimes involves a team of doctors, okay? But it's really important for the first question out of your mouth when you're diagnosed with stage 4 rectal or stage 4 colon cancer is there a curative approach I can take? Because that's something you might want to take. Certainly, we're very aggressive about chasing cure if it's possible. Remember, you don't have an expiration date. Remember to play chess, not checkers. And remember to build your personalized treatment map based on the comment-based options. So let's start talking about some of this. So let's talk about clinical trials for a moment. So clinical trials, as everyone knows, are experiments designed to save lives, okay? We're basically testing drugs to attack stage 4 colon, stage 4 rectal cancer that are not already conventionally approved. This is really important to ask about, okay? There are different stages or different phases of clinical trials. That's not terribly important, but I just need you to ask your oncologist about it. If you want to look them up yourself, you just go to clinicaltrials.gov. You can watch that very first lecture I alluded to at the beginning. I will post this on YouTube. You'll see it. The bottom line is you can go back to the first lecture and see how to do this. So here's the 8 essential questions we need to ask for a stage 4 colon patient, stage 4 rectal cancer patient, okay? 8 questions. I'm going to walk you through all of these. So please don't worry. But you could literally just take this slide with you, can print this out, right? Take it with you and just bring these questions to your doctor. I made it super easy, okay? I try to make it as easy as possible for you. So let's talk about these questions. So question 1, is there a potential curative approach one can take? This is based on the location of the cancer. Is it in the liver? Is it in the lung? Okay, it's based on how much. So if there's like a solitary spot in the lung or a solitary spot in the liver, that would be curable, right? All things being equal. It's based on your functional status. So are you somebody who has a pretty good functional status? You're pretty active. That would be part of what we would take into consideration than other medical conditions. But question 1 is always, is there a curative approach you can take? So sometimes that will involve liver resection, so taking out a tumor in the liver. Sometimes it involves taking out a tumor in the lung. Sometimes it involves liver transplant. Now, this is a little intense, okay? We didn't used to think like this, but recently, Mayo Clinic Jacksonville, for example, is starting to do liver transplant for patients who have just liver disease that's not amenable to just taking out one spot. Now, this gets really complicated. I want to be a little bit careful here because this is not mainstream yet, right? But the bottom line is some people even do liver transplant, which basically means sometimes it's not obvious what's curable and what's not. Sometimes your oncologist won't have a good feel for it. Like me, for example, right? When I look at someone's scan, I might look at it and say, oh, that's a lot of liver disease. I think that's incurable. But I always ask my surgeon, because sometimes I'm wrong, right? It may look like it's not curable to you, or maybe may not look like there's a role for surgery, but then you talk to the surgeon like, no, I can do something about this. Just reduce the cancer for me, then I'm going to come in behind it. So you may even want to say to your oncologist, hey, can I just get a second opinion from a liver surgeon, just somebody who can look at this? You know, it may not be obvious to the cancer doctor, I promise you. I've been kind of shocked by what people are willing to do surgery on, and they're right, and it's great. So please inquire aggressively about this. Now, remember, if you just take out the liver spot and you leave the cancer in the colon or the rectum, that's a problem. So when you're trying to cure someone, you're not only going to take out the metastatic deposit, the liver, the lung, whatever there is, but you're also going to remove the primary tumor where it started. You know, if it came from the colon, went to the liver, you got to remove the colon and the liver, right? If it came from the rectum, went to the liver, you got to remove the rectum and the liver. Now, there's one distinction here between stage 4 rectal cancer and stage 4 colon. With stage 4 rectal cancer, you will likely also get chemotherapy and radiation to the rectal cancer area if they're trying to cure you. So you would not just get surgery, you would also get radiation with chemo, as opposed to a colon cancer patient would just get surgery. So surgery can still be helpful even if the cancer isn't curable. So this is something to remember. It's important. So yes, we want to try and cure you, but sometimes we do something called debulking surgery. So debulking surgery would be where we take out certain facets of the cancer because we're trying to prolong your life. Now, I've had patients with a tremendous amount of abdominal disease, colon cancer or rectal cancer. We've removed it and they're alive 10 years later because we removed it. I actually have several patients like that. I can show you an example. I think I'm showing you an example in a moment, but we do a lot of that. So please ask your doctor about that. So the bottom line is, okay, you've got to ask about the role of surgery when you have stage 4 colon or stage 4 rectal cancer. That's very different than breast cancer, very different than lung cancer for the most part. With stage 4 colon, stage 4 rectal cancer, you've got to ask about surgery. You've got to ask about cure. So let's talk about this patient. I've been showing this actually, I think, quite a bit during this talk. This patient has one spot in the liver. You could resect that, take out the colon primary, and you have a pretty good chance at cure. So absolutely, this patient should chase cure, all things being equal. So here's another patient, solitary spot in the liver. You can kind of see over time, nothing else has grown. So this patient will be chasing cure as a patient of mine, right? So we'll take out the colon cancer and we'll take out that spot. Here's a patient who had a very big mass in the belly from the colon cancer. It's a colon cancer deposit that basically was very big, also involved the liver. Now, this is not a patient you can cure, okay? But what we did is we took out this mass, and you can see now a year later, there's nothing there. Actually, 2 years later, there's nothing there. She's got no evidence of disease. So she's doing great. But this is something actually you have to be very aggressive with. Now I'll tell you the story here. Tell you a story. I first met this patient a little bit roughly around this time, March 2021. She had already been to a big name institution, gigantic name institution. That institution said no role for surgery. We're not going to cut this out. Well, I thought that was absurd. So I asked another person and they also said no, but they said no because the big name institution said no. So that really bothered me, really perturbed me because all I cared was my patient, right? So I gave them chemotherapy up front. The liver spot they had went away. I'm not showing that here, but it went away. Things got better, but this mass got bigger. So like, that's it. We got to take this out. So I went to another surgeon. I said, hey, you got to take this out with me. I can't keep doing this. So they took it out. And now 2 years later, she's fine. Almost 2 years, so a year and a half later, sorry. This is actually 6 months later, but a year and a half later, I'm not showing the scan, she's fine. So this is really good. And debulking surgery can play a very big role. I have another story, actually, a 19-year-old patient, stage 4 colon cancer, to the ovaries, to the belly, etc. We did surgery after surgery after surgery in her, and she lived for a very long time. And so it's important to ask about this, okay? So I want you to aggressively inquire about surgery. Often there's many right answers. So don't say, you know, Bassem said this, don't go to your physician. Not my first thing, Bassem say, Bassem told me this. Well, he's going to say, who the hell is Bassem, first of all? And I agree with him. Okay, the bottom line is there's many right answers. I'm not here to replace your oncologist. I'm trying to just give you a feel, okay? So you can see in this patient, you could remove this lung spot if that's all they had. And here, actually, this is an interesting case. This patient, right, had disease that got worse in the liver. They did a liver transplant in essentially 2 year later or a year later, no evidence of cancer. Actually, 3 years out, I was told that this patient is doing well. So you can see here that this is not a patient you would think you could cure, but now it looks like they might be cured with the liver transplant. So we'll see. But the bottom line is you've got to ask about this stuff. You've got to kind of push your physician a little bit. Even someone like me, you know, like my patients say, is there a role for surgery? I have to kind of, you know, take a second thought and be like, hey, maybe I need to get someone else involved. It may not look like it, but, you know, I don't know the answer to this. So I always get someone involved. Remember, they're going to remove the metastatic site and the primary colon cancer, or the rectal cancer, they're trying to cure it. There's different sorts of combinations of therapies you can use to try and cure something. Let me explain that. So you might have a patient with just a solitary spot in the liver and one spot in the lung, and they might not be a good candidate for having the lung spot removed. So what you might do is you might take out the liver spot and you might radiate the lung spot, or you might radiate both, right? The bottom line is there's lots of combinations of treatments we use to be very aggressive with colon cancer. I trained under a guy named George Fisher at Stanford, and I was there from 2008 to 2012, learning cancer in blood and doing my postdoc in biochemistry there. And he was very aggressive. And, at the time, I don't think that was really mainstream, but he was remarkably aggressive in his approach. He was a phenomenal doctor, one of the best in the world. And so learning from him was really nice. I like being aggressive in this disease. Now, question 2. So we're done with question 1. Question 2, does the cancer have high microcellular instability and or is it mismatch repair deficient? So MSI high or MR deficient, super easy. If the answer is yes, we can use immune therapy, and there's different options I'm showing you here. I made this super simple for you, right? I know it was a little complicated earlier, and I kind of didn't do the best job explaining that, not my typical approach. But the bottom line is I'm doing it again here so you can understand it, okay? So if your cancer is MSI high or mismatch repair deficient, we can use immune therapy. Lots of different options here. So either Keytruda, Opdivo, Jemperli, or Yervoy plus Opdivo. And essentially the answer to this question, if it's yes, means you can get immunotherapy. If it's not, the answer is you can't. The other thing to ask them, though, kind of a secondary question, is the cancer TMB high and or PD-L1 positive? So does it make PD-L1 like we talked about earlier, or does it have a high number of tumor mutation burdens? If the answer is yes there, then you might be a candidate for immunotherapy. It's a little bit of a softer call. It's not as profound a call as if you're MSI high or mismatch repair deficient. If you are one of those, they're going to start with immune therapy. It's almost a given, unless you have some sort of contraindication where we can't do it, okay? But these are softer calls, but please ask about them, okay? So you can see this patient, I showed it earlier. They were MSI high, big mass here in the belly. It gets, in the belly, gets a lot better with treatment, okay? So really, really good. So again, here's your different sorts of options. To me, they're all essentially the same. I won't go through this too much. I'll go through it actually next time in the next lecture. I'm gonna go through all the side effects and everything. I won't go through it too much now. So question 3 and 4, okay? Are you a candidate for an EGFR inhibitor? I'm gonna come, so basically what we're trying to decide, okay, is we have drugs that target a protein called EGFR on the surface of the cell. I talked about it earlier. We have 2 drugs, cetuximab and panitumumab, okay? So we need to determine if we can use these drugs in you. So question 3, which I'm gonna show a little bit better in a moment, is your cancer right-sided or left-sided? Well, what do I mean by that? So you can see this very nice diagram here, okay, from colorectal cancer reports. I did not make this. This very nice diagram here, okay, which shows that if your cancer is right-sided, so this is the transverse colon, ascending colon cecum. So if it's right-sided, then you are not a candidate for an EGFR inhibitor. So there's no benefit to using one of these 2 drugs. So if your cancer is in the ascending colon, the cecum, or the proximal transverse colon, you are not a good candidate for an EGFR inhibitor. However, okay, if your cancer is on the left side, if it's in the rectum, the sigmoid colon, the descending colon, and part of the transverse colon, then you are a good candidate for these drugs, cetuximab and panitumumab. I'm going to go over that more later. But one of the questions I want you answering is my cancer right-sided or left-sided? And the reason I want you answering that is because it will also answer whether or not you can get these 2 drugs, okay? So the other question, question 4, is there a mutation in that RAS protein we talked about, KRAS, NRAS, or HRAS? If there is a mutation, you are not a candidate for these 2 drugs. If there is no mutation, then you are. Okay, so what does that mean? Well, to be a candidate for cetuximab or panitumumab, your cancer has to be left-sided, and it cannot have one of these mutations. Super simple. That's all you need to know. Okay, so here's question 3 and 4. So I made it super easy. You can print out that earlier sort of question list I gave you. But is the cancer right-sided or left-sided? Right-sided means you can't get the drug. Left-sided, you can. Does it have mutation in this RAS protein, RAS gene? If it does, you can't use it. If it doesn't, you can. That's it. Super easy, super simple. Just follow the question list. Super easy. Okay, come back to it. Right now, I don't expect you to get all this. This is complicated, but it's actually really easy when you look at it. Question 5, can we use a drug that targets this BRAF V600E mutation? If you have, so the question basically is, does the cancer have the mutation? Okay, so if your cancer has this mutation, this BRAF V600E mutation, just ask your doctor, it's from that molecular profiling, then we can treat you with a drug called encorafenib, which targets that mutant protein. And we also will give you cetuximab combined with that, okay? So really what you're trying to figure out is, are you a candidate for this combination treatment? And the answer will come if you have this mutation, you are. If you don't, you are not. That's question 5. So question 6, are you a candidate for a drug that targets this HER2 protein? Okay, so question 6 really is, does the cancer have HER2 amplification? Does it overexpress this HER2 protein? If it does, then you're a candidate for these 2 drugs that target that protein. If it doesn't, you're not, okay? Now remember, I talked about tucatinib, which I think is going to get approved. Very nice data recently on this drug. So if it has this HER2 implication, you can get both of these drugs also on trial. I think they're going to get approved. But again, just answer this question, you'll be good. Question 7, if there's disease that has spread, okay, and you're not a candidate for cure, you want to know, is most of my disease restricted to the liver? Why is that? Well, we have treatments that can target liver-only disease or liver-predominant disease, those local regional procedures I was talking about. We have a bunch of them. We have something called radioembolization. Remember, it's those beads coated with radiation. We basically inject them into the arteries that feed the liver, okay? We have something called yttrium-90, Serspheres, Theraspheres, et cetera. You're going to hear these words, okay? We also, if there's like a spot we can get at, we can just basically microwave them, or we can do radiofrequency ablation, right? And if it's a lung lesion, we can actually do what's called stereotactic body radiation therapy, just pinpoint radiation to try and get rid of it. So the bottom line, though, is you want to know, are the metastases in the liver predominantly in the liver, or are they elsewhere? Okay, that's question 7. And then one other question I should have put in here is, is the lung lesion something that's amenable to radiation? That's also a question you can ask. And so here's examples of local regions and everything else box, that common acronym, that E part I talked about, local region options we can use. So here's this radioembolization I was talking about. We inject these radiation beads into the liver to attack the cancers in the liver, okay? Here's something else called transarterial chemoembolization, that we basically inject chemo directly into a liver spot. That's not so widely used in liver cancer. We would more likely use something like this. But remember, you can do ablation, you can do hepatic arterial infusions, but this is important to understand that there are some things we can use. Forget these last 2 lines, they should not be there. It's not hepatocellular carcinoma. I'm talking about liver. I'm sorry about colon, okay. So question 8, are there other molecular abnormalities we can attack? So if there are, you might want to use a corresponding drug that targets those molecular abnormalities. So something like NTRK, BRCA1 or 2. So if you have mutations in BRCA1 or 2, we can use a drug called olaparib, some sort of polyadipose polymerase inhibitor. So olaparib, rucaparib, veliparib, niraparib, and so talirzoparib. So there's drugs we can use to target those. NTRK fusions, we can use entrectinib or larotrectinib. So the bottom line is, you're going to say to your physician, are there other molecular abnormalities we can attack? Okay. So here's the 8-question list. We just went through all of them. Just write down this list, okay? Take it with you, get the answers, and now you're good to go. Now you'll know a whole lot about what's going to happen to you. So what we're going to do next week, okay, is we're going to go through treatment. So I'm going to give you, I think, a world-class premier lecture on treatment. You're not going to get anywhere else. I'm going to talk about new clinical trials, new drugs in trial. I'm going to really push the envelope because I think patients can handle it. I think you guys can handle it. So we're going to really go through that next week. What we're going to do is we're going to kind of build these treatment maps we talked about, okay? And so that's a preview for next week. We're going to get stage 4 colon next week, stage 4 rectal cancer, probably next week, the week after. We're going to walk you through your journey, okay? But in knowing your journey, please know that conventional options, the C, are going to play a central role. Surgery is often very important. Molecular studies are essential. The local regional options we talked about are oftentimes very important. If you have liver disease only, clinical trials are essential. So this gives you a slight preview of what we're going to talk about next week. So I kind of broke it up into the different classes of drugs we use, okay? And I'm going to make it super easy next week, okay? But we're going to go through all of this next week. This gives you a very nice preview, gives you a reason to come back. But we're going to go through this in a sequential manner. I'm going to do this super easily for you, okay? So we're going to go through the forest and the trees. This kind of shows you what I'm going to do next week. I'm going to kind of go through first-line treatment, second-line treatment. I'm going to show you your entire map. This is what the map looks like, kind of an overview, but I'm going to walk you through this next week. So that's all I have for now. I'm going to just kind of give you the overview today, and next week we're going to give you the kind of the full entree. So today was the appetizer, kind of building up to the entree. Next week's the appetizer, the entree and dessert. Any questions today? Any comments? Any concerns? Awesome. Thank you for spending your kind of hour with us on a Saturday. We will come back next week. We'll go through stage 4 colon cancer treatment next week. All right, guys, take care. Thanks so much. Have a good one.